honor for us to have Dr. Angelos Kolias during our symposium. He's a consultant neurosurgeon in Cambridge, in the UK, and he's the chair of the WFNS Young Neurosurgeon Forum. But most importantly, he has mentored many young neurosurgeons, supporting them in research, especially those from LMICs. So, Angelos, we are very grateful for your presence here today, and we are looking forward to your lecture. Much welcome.
Great, thank you. Thank you very much, Ignatius and Tsega and Bev and Comble. It's my pleasure being here today. I'll show a few slides, and then Brandon Smith, one of our PhD students, will also continue with my talk. So can you all see my screen?
Yes, Angelos.
Great. Okay, so this. So if you, I think you know this. So the group, the NIHR Global Health Research Group on Neurotrauma. A few talks have mentioned this. So just to recap, so this is a group that received funding from the UK government, and it was set up back in 2007 now. So it's been a few years. The total grant was about £2 million. So that was a sizable investment from the UK aid. And they also fund quite a few other groups, amongst them also a group on global surgery. And this is a group, for example, that has very successfully launched now the COVID surge studies that have been supported by the WFNS and also the Young Neurosurgeons Forum of the WFNS. So I think, as an investment in global health and global surgery, this seems to be working well. Obviously, Tony Figaji previously mentioned a few issues with his efforts, but I think things are improving. The situation is getting better. So as I say, the launch meeting was back in September 2017, and this was something that was launched with the WFNS, the World Federation of Anesthesia, the Royal College of Surgeons, and also institutions from several countries. And it was LMICs. So this is the map of the current LMICs. And you can see that we have a representation from Latin America, Africa, and Asia. And a few months ago, we submitted a new application for renewal of this program and actually expansion of this program. And the number of countries has increased. So now we are delighted also to have formally Cameroon and Philippines on board in this new application. And Tony Figaji is the co-director of this new group. We don't have the news yet, but hopefully we very much hope that it is going to be funded. But we'll have to wait and see what happens. So the current group, that's the website. Anybody who's interested, you can look it up and you can find more information there. This is a picture from the launch meeting, and the group has been organized around 4 themes. And theme 1 is about mapping TBI care. So this is, for example, where the Zeno study and the WFNS trauma registry fall under. Then theme 2 is about understanding TBI care provision. And this is a slightly more in-depth methodology. So this is work that's been taking place so far in Myanmar, but it is a very much in-depth methodology with design engineering aspects as well. And then theme 3 is innovation in TBI care. And you can see that this was split in sub-themes. And the collection of long-term outcomes was one of those sub-themes. And then theme 4 is about building TBI research capacity. And I think Tony Figaji made a very valid point that the agenda is often dictated by high-income countries rather than the LMICs. But I have to say that both in this program a few years ago and also with a renewal of the new program that we applied for, in fact, we invited our collaborators from LMICs to submit research ideas, and we didn't actually submit our own ideas. That was all driven by LMICs, and I think this is a critical issue. So TBI is a silent epidemic. The problem is that you can't manage what you don't measure, and this is very true, I think, also in TBI. The question is, which outcomes should we be measuring? And I'll briefly introduce the concept of a core outcome set. So this is an agreed, standardized set of outcomes. Can be a number of outcomes, and it usually is a number of outcomes that should be measured and reported as a minimum. So it doesn't mean that you shouldn't collect anything more, but this is what you should be collecting at the very minimum in all clinical trials and studies in a specific area. And this is the common definition. The definition from the US NIH is very, very similar. In the US, they, for example, call this CDE. But they are known as core outcome, common outcome sets, common data elements. And the advantages of such a set is that you have increased consistency across various studies. And then if you are using such a core outcome set, you're maximizing the potential for a study to contribute to systematic reviews. Anybody who has tried to do a systematic review will have seen that actually it's very difficult to synthesize the studies because they have different outcomes. If they have similar outcomes, often they are being measured at different time points. So a study using a core outcome set is much more likely to measure outcomes of interest. And then also, hopefully, we'll have a reduction in the selective reporting. Again, selective reporting is a problem. So, this is, especially in big randomized trials, this doesn't really apply to retrospective studies. But in some big randomized trials, people are selectively reporting the outcomes which are significant in terms of statistical significance. And thankfully, in TBI, some efforts to define a core outcome set already exist. And this is a publication that I think anybody who is interested in TBI should have a look at. Is open access, so you can access it online. Published now a decade ago, and you can see the domains on the left-hand side of the screen. So you have the outcome domains as opposed to specific outcome scales. And I'll explain in a minute what I mean by this. And then you have the domain description and the relevance in TBI. So domain would be a global outcome, and this is for example, to summarize the overall impact of the TBI. So the Glasgow outcome scale is such a scale. The slight issue is that we can agree on the domains, but there are also the specific outcome scales that come under each of those domains. And I think there is more work which is ongoing there. Because it's not immediately apparent which of those scales we should be using. I think the Glasgow outcome scale, the extended one, is very well accepted nowadays. But in terms of, for example, how to assess neuropsychological impairment, psychological status, it's not that clear. And then in terms of other domains, just to mention a few: behavioral function, cognitive ability, physical function, social role participation, and vocational also outcomes are important. So, returning to work, what type of work, and also the quality of life. I think it's very, very important. And now, in terms of outcomes, yes, we agree that we should be collecting outcomes, a number of outcomes. Mortality is not everything that we should be collecting, although mortality is important. The issue is how long should we be following up patients with a TBI for, especially in the context of research. And this is a nice study published by David Okonkwo's group in 2019. And you can see that these are all patients with severe TBI. It's secondary analysis of a randomized trial, so they had very good quality data. And you can see at 30 days, the blue is the patients who are dead. Then you have VS. Then you have lower severe disability in green, and in purple you have upper severe disability. So with a traditional dichotomy, everything which is above that line would be a good outcome. Everything below would be a poor outcome. there are some discussions about the dichotomy, but the point is you can see at 30 days, you have more than 80% of the patients with a so-called poor outcome. But then if you assess them again at 90 days, you can see the sort of improvement. And then if you assess them again at 6 months, you can see even more improvement, to the extent that actually now the majority of patients have a good outcome. So, it is clear that patients in TBI, and we all know this as clinicians, patients in TBI, they do improve over time. In fact, in the rescue ICP study, we found improvement in the surgical arm from 6 to 12 and also from 12 to 24 months. And we're preparing this for publication now. And is it long-term really necessary? I think, I've shown that there is improvement, but one could say, okay, we know that people improve, why bother? So this is the trial of dexamethasone for chronic subdural hematoma that we recently published. And this is the table with the key outcomes. And you can see here, so this is the dexamethasone group, and this is the placebo group. And you can see that if you were just looking at recurrence, so the recurrence in the dexamethasone group was 1.7%, in the placebo 7.1%, so it was higher. And then if you were only assessing the outcome at discharge with a modified Rankin scale, you can see that it's not different. This is the 95% confidence interval. It crosses 0, so it's not significant. So if we had just stopped at this point with the study, the outcome of this study would have been that we should be using dexamethasone, because the recurrence is lower and the outcome at discharge is equivalent, you could say, in both arms. We carried on, though, and we assessed the outcomes at 3 months and 6 months. And you can see now why it is important to follow our patients over time. So at 6 months, you can see that actually 90% of the placebo group had a good outcome, as opposed to 84% in the dexamethasone. So patients who received dexamethasone actually did worse. And this was significant, the p-value 0.01, and exactly the same picture also at 3 months. Patients who had received dexamethasone had a worse outcome. So now suddenly you have a conclusion which is very different to the conclusion you would have had if you had stopped at discharge. And the conclusion was that we should not be using dexamethasone in this context. So I think that nicely exemplifies why we should be collecting long-term outcome, at least in the context of studies. So there are various people to acknowledge. You can see the list there. I won't specifically name anyone, but I'd like to pass on now the button to Brandon Smith, if that's okay. Is Brandon there?
Excellent. I'm here. Just going to share my screen. Okay, can you see this?
Yeah, it's visible, Brandon.
Excellent.
Yeah.
Perfect. Okay, well, good evening, everybody, and thank you very much for inviting me to this global webinar. My name is Brendan, and as Angelos has kindly mentioned, I'm one of the PhD students in the group, exploring the contextual challenges of long-term outcome collection and follow-up after TBI in low and middle-income countries. So, firstly, why are we exploring the follow-up of TBI and the collection of outcome measures? I'm sure the scale of TBI has been highlighted many times today already. However, just to drive the point home, I shall refer to some statistics that act as the driving factor for my research. So in 2010, there was 5 million deaths as a result of all injuries, making up 10% of global deaths in the world at the time in 2010. And of these deaths that were trauma-related, 89% occurred in LMICs. So quite a large amount. And when we look at the global incidence of all-cause, all-severity TBIs from this pool of data, they're estimated at occurring of around about 940 or so per 100,000 population, which when we do the maths equates to around about 69 million each year. But the issue is these values may be considerably underestimated, as neurotrauma incidence data as a whole is fairly sparse. So TBI has a large socioeconomic burden, as we all know, when we consider the direct and indirect costs this pathology has on the patients, their families, and the wider economy, and is estimated to cost the economy roughly $400 billion annually. And to put this into perspective, that's almost 0.5% of the entire annual economic output per year. So the World Health Organization recognizes that there's a difference in patient outcomes following these sort of injuries in high-income countries versus low-income countries, with LMIC healthcare providers facing a burden of almost 3 times that as many all-cause TBI cases than in high-income countries. However, again, as I mentioned, these figures may be underestimated or may even paint a slightly different picture than reality due to the sparsity of the neurotrauma incidence data. And as globally as a whole, outcome data is not reliably recorded long-term. And the guidelines for essential trauma care released by the World Health Organization summarizes this quite well and underlines the purpose of my research. As they state, to fully understand the burden of a disease, we must evaluate disability as well as death. And this is where my research currently being conducted in the group falls into place and hopes to shed some light on the challenges that LMIC neurosurgical centers face in the collection of these long-term outcomes and the difficulties that they may face in doing so. So just again, to summarize, very little is published in the literature about the difficulties of long-term follow-up within LMICs and what specific challenges that they face within these countries. And without an in-depth understanding of these challenges, it won't be possible to make recommendations or suggest ways that we can improve the collection of these long-term outcomes into the future. So my study is exploratory in nature and is a qualitative study. So we're based around interviews, and we're inviting physicians with neurotrauma experience to explore the challenges they face in full, with the aim to determine current approaches of follow-up, explore challenges associated with this, and altogether to collaboratively offer recommendations for the solutions to facilitate the long-term follow-up in the future. So as I mentioned, interviews have already begun with an example of some of the topics we're exploring found in the table on the right. And we are still seeking to hear from a number of LMICs to paint a fuller picture of the contextual challenges faced globally. So to finish, it's my pleasure to invite neurosurgeons from low and middle income countries to consider participating, and we'd be most grateful to hear of your experiences and perspectives. And for further information of the study, please do get in contact with myself at this email or with Angelos as well. Thank you very much.
Thank you very much, Brandon. So we will proceed with the next presentation by Dr. Tsegazeab Laeke. So Dr. Abdulaziz is a new graduate from Ethiopia, Addis Ababa University. He is now working at Hawassa University Hospital. So he'll be presenting on clinical outcomes and prognostic determinants of surgically treated depressed skull fractures. You can proceed, Abdulaziz.
Yeah, thank you so much, Professor Tsega and all others. My name is Abdulaziz, as Professor Tsega said. The authors, it's me and Dr. Tsega himself. Our title was Clinical Outcomes and Prognostic Determinants of Surgically Treated Depressed skull fractures in Addis Ababa University. To begin with, head injury is one of the most important public health problems worldwide, especially in African continent and other developing countries. And from this, depressed skull fracture is one of the most common type of TBI, and is also one of the common neurosurgical emergency in these head injury patients. So our objective was to assess the clinical outcomes and identify the predictors of the outcome in surgically treated adult patients who was having a depressed skull fracture. Our methodology, it was a hospital-based, multi-center prospective observational study in 4 hospitals in Addis Ababa that provides neurosurgical service. The study period was 24 months period, which was conducted in 24 months period, and we included only adult patients with depressed skull fracture managed surgically. We excluded those patients having significant epidural hematoma, subdural hematoma, ICH, and we also excluded pediatric patients, and we also excluded patients with penetrating TBI because the outcome is completely different. So with this, we have dozens of independent variables, but our dependent variable was clinical outcome based on extended Glasgow outcome scale at the end of the follow-up. with data collection, it is as usual with pre-designed questionnaire, and we collected and coded and analyzed using SPSS. And to analyze the outcome, we dichotomized the Glasgow, extended the Glasgow outcome scale into two, as favorable and unfavorable. When we say favorable, those having good recovery, and when we say unfavorable, those having moderate disability and worse. So with this, to identify the factors which has association with the outcome, we did bivariate analysis, and those factors which have strong associations, that means the p-value less than 0.05, were taken to multivariate analysis to identify independent predictors of the outcome. With this, our result, the participant total number of patients was 197 within 24 months period. So, as already presented by Dr. Imstrach, majority of the patients were young. 86% was from 15 to 35 years old, and the mean age was also 27 years, and males account for 96%, which was highly significant. And the mechanism of injury, up to 80% was violence related, majorly, which is stick and by stone, which accounts for the majority of mechanism of the injury. The median time for intervention from the time of trauma up to intervention was 72 hours, but up to 60% was intervention was taken within less than 24 hours duration. When you see radiographic findings, the most common site of fracture was frontal fracture, followed by parietal area, and the most common underlying lesion was contusion and hemocephalus. This is one of the images which shows the bone window and brain window, which shows the significance of the depression. And the median hospital stay was 4.7 days, and 9.5% of the patients developed an infection, and the early and late post-traumatic tear was also witnessed in 8.1 and 2.5% of the patients in our study population. Reoperation rate was 4.1%, and the mortality was only 0.5%. So with this, our overall clinical outcome was favorable in 81.2%. For the remaining, it was it means unfavorable. So this is a histogram which shows the outcome, which shows mainly the majority of patients having a favorable outcome. And to identify the independent predictors, as I said, we did bivariate and multivariate analysis. We identified 5 factors which determine the independent predictors of the outcome, which were motor weakness, pneumocephalus on CT scan, and post-resuscitation GCS less than or 13, hospital stay more than 3 days, and the reoperation. All of the factors have significant association with p-value less than 0.05, with adjusted odds ratio, and with a narrow confidence interval, with 95% confidence interval. From all of this, the motor weakness have significant association with this one. To discuss some of the points, the long-term outcome was favorable, as I said before. This is also comparable with proportion with other countries, especially the report from Africa, but a slightly lower number of favorable outcome when compared to other developing countries. From this, motor deficit, as I said, was a major determinant of the outcome. This is maybe due to the one of the concerning impact of the motor deficit is ineffectiveness in labor-intensive work. This is the primary source of income for developing country like farming and daily laboring. As I said, most of our patients was young and the males. Those who for those the major income was by farming and by daily laboring. So having a motor deficit was found to have significant impact on the functionality of our patient. And regarding the other literatures, as far as our knowledge is concerned, there is no data which describes the association between focal neurologic deficit with the outcome of this depressive fracture. So in conclusion, the overall outcome was favorable in our study group, and we identified 5 independent predictors of the unfavorable outcome, which is mainly the presence of motor deficit and having moderate to severe TBI. So with this, we recommend all stakeholders to work to improve pre-hospital care rehabilitation centers in order to improve functional recovery of the patient who's having disability. We also recommend to have attention to be given to medical surgery to reduce post-operative septic leak, deep brain infection, and the subsequent reoperation, which may worsen the outcome. Our limitation was due to COVID-19 global pandemic. We collected data by phone for some of the patients, and our thing is it is prospective, and the other is to the best of our knowledge, the current study is the first to identify independent measures of the clinical outcome in surgically treated patients with DCF. Moreover, our study also was the first to analyze the outcome of the treatment for DCF in Ethiopia. Hence, the result of our study could be major input for the development of management guideline, which can be used as an African continent as general. So I will end up my presentation by some of the Harvey Cushing saying, though many scalp wounds which appear serious prove to be trifling, more which appear to be trifling prove to be serious. So it is wise to know what predicts this outcome and act accordingly. Thank you so much.
Wow, before Tsegazeab takes over with coffee in hand, well done to the young neurosurgeons for keeping time. I think the threat of being cut off has helped. Excellent presentation. We look forward to the rest of the speakers.
Thank you so much.
Thank you very much. So we'll proceed with the next presentation. The next presentation will be a case presentation by Hendrikas Boli from Indonesia. So he will be presenting an interesting case on depressed skull fracture after assault with machete. So I'll give the floor to Dr. Hendrikas.
Okay, it is a great honor to present our experience in management of depressed skull fracture due to a machete assault, and I am Hendrikas Boli from Indonesia. For the introduction, as we know that the traumatic brain injury is leading cause of death and long-term of disability in young people less than 40 years. And alcohol intoxication is one of the risk factors, especially in my place in Indonesia. Here we report 3 cases of depressed skull fracture after assault with the machete after consumed alcoholic drinking. Special case in the New Year party. It's very important for me in my group, in my place, because local interpersonal conflict after alcoholic drinking usually lead to the skull depressed fracture, like our case in here. Our problem also is case management in the era of COVID-19 is also contribute to some delay to manage the cases, and mostly of the patient outcome will be related to the another local tribes of conflict, or even the war of the tribes after the little conflict after they drink the alcoholic and then they have the injury. So a machete for Papuan actually used for the agricultural purpose, and also some for the weapon in war, especially in war, in tribes war, and daily activity also for hunting, cooking, and etc. This is the 3 cases I found in one night in the, especially after the New Year party. The first cases come to me with the all the cases have already get the alcohol intoxication after a small group drinking for the New Year party, and after that they usually have the conflict, and then most of them using the machete to injure the opponent, and this is the case like this. My people in Papua usually use the machete to injure the head directly to the head of the opponent, and then the opponent will injure with the traumatic brain injury, especially for the skull fracture like this. The first case come to me with alcohol intoxication history and also hypothalamic shock when they come to the emergency room with single wound left parietal and small epidural hematome. And the second case with multiple wounds at the left and right parietal, and the last case is he came with the single wound at left frontal extending to the facial bone, and durameter laceration after we performed the head CT scan to evaluate the neuroimaging of the cases. After we performed the operation for 3 cases, they all went home with GCCS 15 without no complications such as the seizure, no wound infection, and they went home, and after 1 week they come to follow up the wound healing. So refer to the management algorithm proposed by Zapata et al. For both neurosurgery. I try to make our algorithm, but in the context of pandemic like now, we face some problem, especially delay in management, delayment in case management, especially for the after we identify the ABC was clear, and after that we have to have some another time to make rapid test, and after that the swab test.
Have 1 minute remaining.
Okay, and after that we can do the head CT scan. The delayment actually falls until 6 hours, and after that we follow the algorithm that proposed, and we also make the getavision and the initial to washing the first initial in the operating room. And for the conclusion, our workflow that we do some adjustment for the Zapata algorithm, we propose that for our workflow is management, especially for mesotelic cranial trauma, have proved useful. The GCS, when the patient admit, the emergency room is very important for Professor factor. Actually, for the re-evaluation after the alcohol intoxication is good, and after the aggressive regimen of intravenous antibiotic and phenytoin, it will be low risk of infection, and the area of melanemic, we are, as the neurosurgeon, have to direct intervention to the ER, not just the general ER doctor. Thank you.
Thank you very much, Dr. Hendrikus. So we'll proceed with the next presentation by Dr. Sawa. Dr. Sawa is a neurosurgeon from Niger, so she will be presenting intriguing findings after traumatic brain injuries.
Thank you very much for this opportunity given to me to present this case report on intriguing finding in a traumatic brain injury. To introduce, we can say that the traumatic brain injury is a leading cause of death in developing countries, and so the mortality rate is still around 35 to 42% despite all improving measures put in place by governments to take care of the patient. Thus, it represents a health and social burden as complications such as infection and neurological disability are concerned. We need to act on various stages to alleviate the severity of the traumatic brain injury and complications, especially infections. Here we present a case of a 22-year-old male referred from a Category 2 health facility 5 hours from Niamey where we are practicing. At the admission, the patient was alert with a Glasgow Coma scale of 15, was aphasic, and presented a right hemiplegia. And at the examination of the head, the patient had a stitch wound on the scalp at the left side. After performing the brain CT scan, we noticed a fracture on the left parietal bone with overlapping and penetrating bone fragment with a concussion inside the parenchyma. We also had the fragment in conflict with the superior sagittal sinus, and we also had air particles inside the parenchyma, helping us to conclude on an open trauma brain injury with indication of surgical management. Unfortunately, we delayed for 5 days because the patient presented also an anemia of 7 grams, and we had difficulty in getting blood for transfusion before and during surgery, whereas he benefited for reanimation with 1,000 milliliters fluid, daily antibiotic therapy, and analgesic with the daily dressing of the wound. Then we took the patient to the theater after that, where we performed a bone flap crossing over the superior sagittal sinus. The tricky findings were a stone of 2 centimeters over 2 with bulk of air mixed with sand, and after that we saw a tear of the dura mater of about 4 centimeters with irregular edges. We then perform an abundant irrigation with isotonic saline, the trimming of necrotic tissue, and plasty of dura mater. The outcome was somehow spectacular. At 3 days, the patient had no fever with a clear surgical wound, and at 1 week, the improvement of dysentery and hemiparesis. He was discharged then under the request of the family. 1 month later, we saw the patient without any stigma or infection, still under treatment. Here, the patient points out the shortcomings of
Dr. Samuel,
primary
you
care.
have 1 minute.
Yes, the primary care, which was poor because we had the inclusion of foreign bodies which stayed in contact with the parenchyma for 7 days. The imagery was unable to detect the foreign bodies, and the antibiotics appears to prevent the infection so far with the quality of the surgical techniques. And then the outcome also was favorable, and it depends on the neurological status of the patient at the admission. We can conclude to say that it still remains a huge socio-economic burden, and the expenses is still on the leaning on the patient's family. The cost here of our patient was about $360. The favorable evolution can be accountable to surgical techniques, and we still need a long-term follow-up to appreciate the final outcome. Thank you for your attention.
Thank you very much, Dr. Sawa, for an interesting case. So the next presentation will be by Dr. Ulrich.
Well, hello everyone, I'm Ulrich Sidney, and I'll be talking about generating local data on the burden of traumatic brain injury. I have no disclosures, and this will be our outline. We've spoken about the burden of traumatic brain injury in Africa today. We know of the clinical burden and equally of the epidemiological burden. So in terms of epidemiological burden, 3.1 million Africans have a traumatic brain injury each year. And most of them are young adult males. But we need to think about the economic burden of traumatic brain injuries as well, not only at the level of the individual, but equally at the level of the family and the nation. The nation loses a lot of GDP because these are often young adult males who are either lose their lives or become handicapped. So why would African neurosurgeons care about all of this? Well, first and foremost, because this affects the outcomes, not only at the level of the hospital, but equally at the level of the country and society. And we know the time is brain. One of the factors that we've identified today and previous literature is the delay in reaching and receiving care for traumatic brain injury and how it affects both disability and mortality. We've spoken extensively about the burden of TBI on the public health system. And what we want to highlight here is information management, which is one of the pillars of a health system. Unfortunately, few African countries have a functioning trauma registry, and the current global burden of disease data relies heavily on models and data which is extrapolated from death certificates. And we don't have, unfortunately, again, disaggregated data at the level of provinces, regions, and even cities. We only have national data for most of it. And like you said earlier, you cannot measure something. If you cannot measure something, then you cannot improve it. So we need to be able to be collecting data. Fortunately, we have information about how to go about this. This was published in the Comprehensive Guidelines for Traumatic Brain Injuries by Kolias et al. Data should be collected for every step of the patient continuum. Specifically, there is a resource out there put out by the WHO, which is the International Registry for Trauma and Emergency Care, which can help in that sense. But equally, another component we cannot neglect is rehabilitation, for which we need to collect data. We're going to need to think local and act globally, and this is where international neurosurgery research collaborators are important. We heard about GNOS today, but we equally had recently a research collaborative born out of South Africa for the African Surgical Outcome Study. And the question begs is, we should be able to have an African neurosurgical outcome study too, so that we collect local data, pull it together and see what are those differences and similarities between the outcomes on the continent. Another important element is sharing the findings. We heard about the fact that the burden is important in Africa, but there are very few research out there. We need to share findings not only with the scientific community, but equally with the population. And that means putting out abstracts, open access publications, and journal clubs. So post-publication communication, we want to highlight this here because again, it impacts how we're going to be collecting data because we're talking with stakeholders and with the population, simplify the information and craft a message for the audience. Finally, we'll say it takes a village to achieve this. And this is where we want to highlight the fact that if we're going to have functioning information management systems, it cannot only be a question of the neurosurgeon, it has to be the nurses, the medical students, the residents, and the hierarchy, administrative hierarchy at the level of the hospital. So going forward to build an information management system for patient outcomes in Africa, we want to think about bringing all the stakeholders to the table to make it happen. These are our references, and thank you very much.
Amazing, Ulrich. Anything less from the founder of the President of Associations of Future African Neurosurgeons, and Ulrich was also the 2019 to 2020 Harvard Global Neurosurgery Initiative. We've worked well with you and your organization, and thank you so much for an excellent talk.
Okay, I'm very happy to meet you in African, and thanks to all. I speak about Syria. We have north of Syria and Aleppo. I have very experience, me and other colleagues in neurotrauma. You know, we have war, bombing, rocket, everything. At Syria, we have many surgeons work at neurotrauma, me and other colleagues. For the neurotrauma and subdural or guns in the skull or the vertebral column, we have results, but not reported all the cases. Reported in our minds, not all reported, and pictures, all, you know, we have very difficult working. You know that, okay? About our clinic here, I speak about COVID-19. COVID-19, I see many cases come to my clinic with right lower limb or left lower limb with LASIK is positive, and I see them after I make a CT scan for chest, it is corona. I tell them that corona, neurological corona. Do you see? Our colleagues hear me?
Yeah, we are hearing you with the interest. Okay. Maybe you can.
And so you know some cases of corona, COVID. It's come to us with headache only and with scratching or with diarrhea. But in our clinic, it come to us with leg pain or right left our limb or right our limb, like neurological. Okay, as root compression. I think without income shock for 3 months, become so many cases of corona. I see come to us. I take CT scan to lumbar CT scan, and I make chest CT scan. I see there is corona with you know, corona on the chest, some white in the chest, and nothing, no disc relapses. This is my.
Thank you so much.
Okay.
For your comments. We really
thank you very much. And other times.
Thank you very much. So we'll proceed with the next session. The next session will be chaired by Professor Kee Park. So this session will be focusing on the role of policy and governance in improving traumatic brain injury management in low and middle income countries. So Ignatius, maybe you can introduce Professor Kee Park.
It's a great honor for me, Kee, who actually doesn't need any introduction. He actually doesn't need any introduction as he's well known. So Kee Surgery Committee, the WFNS, recently he's just came up with one of the global program is going to change the research worldwide, and he's editor-in-chief of the Journal of Global Neurosurgery. But besides that, he has mentored so many medics and neurosurgeons worldwide, including myself and Ulrich, who just spoke a few weeks back. So Professor Kee, we are much honored to have you during this symposium, and thank you so much.
Thank you very much, Ignatius. I'd also like to thank Kee Park for his significant contribution to the start and development of neurosurgical training in Ethiopia. So he had dedicated his time to teaching residents in Ethiopia, including me, coming every year for a few months. And he was also continuously supporting our training program. So we thank Professor Kee Park. Thank you, Kee.
Sakanalo Tsega. Hi, everyone. Can you see this? Is my screen being shared?
Yes, okay, we can see it now.
Yeah, I just want to first congratulate all of you.
Yes,
Tsega and Beverly and Kapile. It's amazing that the level of organization and effort that you guys are showing. And this is an example. This is a symposium. I'm just delighted and honored to be a part of it, and really support your efforts, and congratulations once again. So I'm happy to chair this particular session, looking specifically at role of policy and governance. And I want to try to give a short talk, a framing talk. What does it mean? Why should we care about policy and governance in head injuries, right? Well, I'm going to make a compelling case that it is probably more important in some ways than how to actually take out a blood clot from the head. So let's see here. Here we go. Let me just start off with the definition of global neurosurgery. And this is on the website, globalneurosurgery.org. And I co-chair the committee for WFNS, Global Neurosurgery Committee, with Abdessamad Alouabi from Morocco. The definition that the committee has come up with is the clinical and public health practice of neurosurgery with the primary purpose of ensuring timely, safe, and affordable neurosurgical care to all who need it. It's really about the delivery of services. It's really about health equity and reducing some of the disparities in neurosurgical care that we see, especially in some of the poorer countries. So some of you know, after Ethiopia, my focus changed to Cambodia. And this is me. I know I'm not wearing a helmet. And that's my wife, beautiful wife behind me. But you notice the monks aren't wearing the helmets either. But this was just for the Photoshop, photo op. I actually wore a helmet all the time. But I was living and working in Cambodia at a government hospital, and we collected data, and Ulrich gave a very nice talk about the importance of collecting data, and we did, and it really opened up a whole new level of understanding of what was happening. And I'll share with you, of the people that were admitted for head injuries, from 90% of them were not actually wearing helmets. And then the epidemiology, half of the head injuries were presenting with epidural hematomas. I don't know if there are any high-income country surgeons here right now, but epidurals are going away in the rich countries. I think Franco wrote an article about that. The usage of helmets and protective equipment, epidurals are pretty rare now. Maybe 1 out of 10 hematomas, mostly subdurals, high-velocity injuries. But in places like Cambodia, and I think this would be same in other countries like in sub-Saharan Africa, epidurals are very common. The good news about epidurals, as you all know, is that it's easy to treat and the prognosis is excellent. But we looked at the data and we said, wait a minute, why aren't people wearing helmets, and can we actually drive changes in policy to prevent head injuries? So we looked at the data and said, hey, listen, if you don't wear a helmet, there's about 7-fold increase in odds of presenting with a very severe GCS, and almost 4-fold increase in odds of having to have surgery. And this was data that we collected in Cambodia. And then you had also worsening outcomes. Glasgow outcome scale at discharge was lower for people without wearing helmets. And then we took this data and actually went to press, went to public, and then we published on the general media. This one title is called "Head Injury Data Makes Clear the Need for New Traffic Law," and that was in 2014. And there were other things that we did, and we can't take full credit for it, but the government did implement helmet laws in January 2016. And this is where I think neurosurgeons, I got the first taste of policy intervention, right? Collecting data, doing research, and saying, listen, can we actually reduce some of the severity of head injuries, or maybe even prevent it by implementing policies and that are effective in preventing these conditions. So that's why policy is important. The other area that policy is important is health policy. How do governments determine what services to invest in and support? And there's, as you know, people have already talked about this. The Lancet Commission on Global Surgery jump-started the global surgery movement. And so when I was in Cambodia, we said, hey, listen, we should be looking at how to strengthen surgical care throughout Cambodia, not just head injury care, but all of surgical care, because we have to move together. Ministry of Health is not going to build neurosurgical hospitals all over the country. They will build hospitals with surgical services that will have to share resources with other services. So we did this in early 2016. So health policy is very important. Now, I came back to US, got a master's in public health, and then I work with the Harvard Global Surgery team. And we work with ministries of health and helping them develop national surgical plans. How do you scale up surgical care for the entire population? And Ethiopia was one of the first countries to actually develop these plans, and our team had some input in implementing that. But there are a number of countries that are developing national surgical strategic plans, multi-year, massive costing, and so these are called surgical obstetrics and anesthesia planning workshops. And the Harvard program in global surgery has been working with many countries and helping them support, at least technically, how to develop these plans. And so we're at like 44 countries right now. I think that's the last count. So these countries are moving forward with massive national level surgical strengthening programs. And neurosurgeons need to be at the table and provide good guidance in this. This is a picture from the Western Pacific area. 37 countries all adopted a regional framework for safe and affordable surgical care. So the case is pretty compelling. I think we've reached a tipping point with a number of countries showing interest in being committed to increasing surgical care. So let's focus on neurosurgery for a minute. We published this in 2016. We said there are 13 million neurosurgical operations needed around the world every year, 13 million. Of that, 5 million is not being done. And most of that in the areas that you all are really familiar with, Sub-Saharan Africa and South and Southeast Asia. So this is a very busy chart, but this is the breakdown of that 13 million. So total operations, total cases that are needed yearly is about 13.7 million. If you look at it, we broke this down into multiple buckets, the TBI and TSI bucket. And let's look at the bottom row here. So out of the 13 million, 6 million are head injuries, okay? Half all neurosurgical operations that are needed around the world every year, half is head injuries. And then, of course, there's spine injuries, which aren't as much. And then if you look at the high income and low income breakdown of the 6 million, 4.5 million occur in developing countries and lower middle income countries. Only about 1.5 are in the high income countries. So it makes perfect sense for global neurosurgery to focus on traumatic injuries of the brain and spine as the first condition to focus on. So that's why we developed this policy document, and this was a conjunction with Dr. Tariq Khan. He was the head of the Neurotrauma Committee of the WFNS, and we have a list of all these people on the advisory group. And what we wanted to do is develop a set of recommendations for ministries of health if they want to strengthen their ability to treat and manage head and spine injuries. What do they need to do? And this went beyond just how to do surgery better, right? And so, and I'll go over it just a little bit. So the rationale was, the proportion of unmet surgical need in developing countries mostly is traumatic, right? And then we said, let's develop system-level policy recommendations for developing countries to manage these conditions. So how do we do that? Well, health system, there's 6 components to a health system, the building blocks, we call it at the WHO: infrastructure, workforce, service delivery, financing, information management, and governance. And then within the traumatic injury, head injury, there's that spectrum of care, starting with surveillance and prevention, like helmets, all the way to pre-hospital care, emergency services, surgical system, this is where we get, we work, and of course, rehabilitation. And Ulrich at the last, talk talked about the 5 parts of the spectrum as it relates to data collection, surveillance, right? But this particular document, we developed this matrix. I'm not going to go through every one of these recommendations, but here's sort of highlights. From surveillance system, these are the recommendations we have. It should be a priority. We should think about implementing trauma registries. I think Ernest is going to talk about this in the next first talk or the next right after me. Prevention, we talked about, comprehensive, mandatory helmet laws, things like that, well-designed and safe roads. Pre-hospital care, absolutely required for emergency services. We got to bring the patient from the point of injury to the hospital in an efficient and safe way. And surgical systems, people talk about, the ministries of health says, well, how many neurosurgeons do we really need to take care of the trauma burdens in our country, neurotrauma? Well, how do we figure that out? So we did the research, did the estimates, and we said, you need at least 1 neurosurgeon for 200,000 people. That gives them something to work with, right? They can set targets based on these recommendations. How close do these facilities have to be? Do we have to bring patients within an hour of injury to a hospital? Well, at least using Cambodian data, we saw that up to 4 hours, the outcome was about the same. But beyond 4 hours, the Glasgow outcome scale deteriorated in a linear fashion. So we're recommending no further than 4 hours for a neurosurgical trauma center for the population to be able to reach. So there's rehabilitation. So one thing what we found during this policy project was it was all based on literature search. And there's a paucity. There's almost very little research being done by neurosurgeons or other people, for that matter, about this kind of knowledge base. So there's a massive gap. The good news is the research output for global neurosurgery is growing exponentially. The bad news is that we're still focusing on things like, how do we treat head injuries better, not how do we better deliver neurosurgical care. So we got to think about that from a public health standpoint, and focus on things like information management, pre-hospital care, surveillance, those kinds of issues. So, and then, Dr. Figaji talked beautifully about the disparities in research output between high-income countries and lower middle-income countries. And I totally agree with that. And so we need to support research capacity building and work towards research equity, right? And in that vein, me and Ignatius, we are with support of Andres Rubiano, are starting a journal of global neurosurgery. And this journal will be no publication fees, 0. Okay, this is not a for-profit making enterprise. No one's going to make money on this. And there's it's open access. It's published, anyone can find it and read it for free. And on top of that, we will give preference to researchers from LMICs and provide research, language, any support that is needed to help them get to a level where they're on par with the others in high-income countries. So I think that's the last slide. Thank you very much. I look forward to hearing the rest of the talks this session.
Thank you, Kee Park.
Thank you very much. The next speaker was meant to be Ernest Bartholomew, who sadly cannot join us today, but he sent us a video. We'll put the link in the chat box, and you'll have the opportunity to have a look at it. So I'll hand over to Professor Laeke to move on to the next speaker.
Thank you, Beverly. So our next speaker will be Dr. Jeff from Democratic Republic of Congo. So I'll give the floor to Ignatius to introduce Dr. Jeff.
Yeah, thank you so much. Dr. Jeff Talaja is a consultant neurosurgeon in Kinshasa, but in fact, he's setting a lot of neurosurgical departments all over RODC. He's a very active member of the Young African Neurosurgeons Forum, and in fact, We always say thank you to him for organizing the first and the largest meeting we ever had in Kinshasa in 2019. Jeff is also a member of the WFNS Global Neurosurgery Committee. So Jeff, you are welcome to this symposium.
Thank you very much, Ignacio. Thank you very much for my invitation for this good meeting. I will present, but my presentation is not for brain trauma, but they tell me to present about the evolution of neurotrauma in DRC.
So the next speaker will be Dr. Tsegazeab Franco from Morocco. So he will be presenting on severe traumatic brain injury, benefit of decompressive craniectomy, a single institutional cross-sectional study.
Can I share my screen? Can I share my screen?
Yeah, you can share your screen.
Can I begin?
Yeah, you can begin.
I'm very happy today to be part of this amazing symposium. I'm Dr. Tsegazeab Francois from Morocco. I will present on severe traumatic brain injury, the benefit of decompressive craniectomy, a single institutional cross-sectional study at CHU Ibn Sina in Morocco. In introduction, after traumatic brain injury, there is many focal and diffuse lesions will lead to the increasing of intracranial pressure. Elevated intracranial pressure is one of the most common causes of death and disability following a severe traumatic brain injury. Decompressive craniectomy is a surgical option to manage elevated ICP that is refractory to medical treatment. The aim of our study is to evaluate the benefit of decompressive craniectomy in patients admitted with traumatic brain injury. Matter and methods. This is a retrospective case study performed from January 2018 to July 2019 at Ibn Sina Hospital in Morocco. We include patients with severe traumatic brain injury with clinical and radiological evidence of intracranial pressure hypertension who were refractory to first-year therapy. We use SPSS software to do statistic study. For data collection, we collect demographic characteristics, the time of admission post-injury, the Glasgow Coma Scale and pupil condition, the CT cerebral lesion, and the Glasgow outcome at discharge. We divide our patients in three groups: the group of decompressive craniectomy, the group of patients who were managed medically, and a third group of patients who has underwent evacuation of epidural hematoma without decompressive craniectomy. As a result, we collect 85 patients. In them, 20 have benefited from decompressive craniectomy. 9 has underwent evacuation of an epidural hematoma without decompressive craniectomy. And 56 were managed medically. In those, we have 21 presenting same clinical and CT characteristic as the operated group. In the group of decompressive craniectomy, we have 18 patients who were male and only 2 were female. The mode of injury, we have a road traffic accident in 15 patients, followed by the fall of weight in 4 patients, and work accident in 1 case. And the most of our patients are young. The Glasgow outcome scale, as you see in this table, we have 15 patients who were deaf, and only 5 remains alive. The relation between Glasgow Coma Scale and the Glasgow Outcome Scale, in patients who were admitted with a Glasgow Coma Scale between 3 and 18, we have only 73% who 70% who are deaf, and only 22 who remains alive. And in patients who were admitted with a Glasgow Coma Scale between 9 and 13, with second deterioration of scale, we have only 18. We have 18% who are deaf, and only 20 who were alive. Comparison between the decompressive craniectomy group and the patient who were managed medically. We have 20%. You have 20 in the group of decompressive craniectomy and 21 in the group who were managed medically. The mean age was 37 in the group of the comprehensive craniotomy and 34 in the group who were managed medically. In the Glasgow outcome scale, we can see that we have 15 patients, 15 who were deaf in the group of the comprehensive craniotomy and 14 in the group who were managed medically, and only 5 who remains alive in the group of the comprehensive craniotomy versus 7 in the group who were managed medically. In the discussion, the comprehensive craniotomy is performed to reduce intracranial pressure and the need of prolonged medical treatment for intracranial hypertension. It's used to improve cerebral perfusion and decrease mortality and morbidity associated with intracranial hypertension. In our study, the comprehensive craniotomy was carried out to reduce intracranial pressure based on CT cerebral criteria by the lack of the monitoring of ICP or Doppler or transcranial Doppler. The rate of mortality was high, 75% in the group of patients who received the comprehensive craniotomy versus 66% in the group of non-operated patients. We have 19 who has good recovery in the group of non-operated versus 15% in the group of the comprehensive craniotomy. The functional prognosis is more average in non-operated patients than the operated patient. In our study, the comprehensive craniotomy does not reduce neither mortality nor the functional outcome of our patient. As conclusion, we need to have more study with a higher number of patients. We must include transcranial Doppler in the decision making, and we have to select correctly patients who must undergo the comprehensive craniotomy. And the comprehensive craniotomy must be done at the right time to have better outcome. Thank you for attention.
Thank you very much, Dr. Adu, for keeping time, and we will proceed with Dr. Jeff's presentation. He is ready now. So if you have any questions, you can drop it in the chat box. Thank you. So maybe, yeah, we can proceed to Dr. Daniel's presentation until Jeff and Maria get prepared. So Dr. Daniel, are you ready? Dr. Daniel Kenyatta is a neurosurgeon from Kenya. So he will be presenting about neurosurgical trauma life support, salvaging neurosurgical emergencies in the era of universal healthcare. So okay. Dr. Daniel, you can start screen sharing.
Thank you for this opportunity to present this illustrious audience. Let me just put the presenter's view. So one second. So I'm a neurosurgeon in Kenyatta University Hospital in Nairobi. Neurotrauma is one of my passions. And we came up with this algorithm for resource constraint settings. And I thought I'd share it with the panel to see what their thoughts are. So the epidemiology in Kenya is the same as any other low LMIC. We have road traffic accidents, falls, and assault as our main causes of traumatic brain injury. My preliminary experience with this algorithm was when I was a neurosurgical resident. I was the only neurosurgical resident in a public hospital, and I was being supported by other residents. So we had to get them up to speed on how to manage traumatic brain injury pretty quickly, because they were thrown in the deep end, and it was easy to make mistakes. So I finished my training, and I was posted to another public hospital which didn't have any neurosurgical services, which is where now I'm starting the service as a lone neurosurgeon supported by medical officers. So I revived my tool, and I've implemented it in my hospital. So this is a coverage of neurosurgical services in Kenya. We can see 43% of our population is covered within 2 hours of injury occurring. And this is, by basic services, we mean just simple bar holds or craniotomy plus anesthesia by paramedics. So a large portion of the population is not covered. So our hypothesis was, if we implement this neurotrauma life support algorithm, and I'll share some of the papers that I've been using in my setup, would it improve clinical outcome of individuals presenting with TBI? We know for one that we have poor outcomes in TBI because of the length, the poor referral systems there, and our bottlenecks are limited access to skilled neurosurgical services. We have simplified this tool, and we're going to evaluate it and see whether it improves our outcomes there. So it's based on the guidelines for surgical management, traumatic brain injury, the American Association of Neurosurgeons consensus document in 2006, and it creates a common language that can be utilized by anyone, especially the most junior members of staff. And examples of these are acute trauma life support of the American College of Surgeons, or ETAT, the pediatric algorithm for management of pediatric emergencies. These were the goals of my algorithm, and I'll go through some of the forms that we came up with and we've been using. For examination of patients, you can see you have a nice, easy form that, first of all, you check whether the ATLS protocols were
remaining.
Oh, thank you. And you can easily characterize the Glasgow Coma Scale. These are the typical clinical traumatic brain injury syndromes that you see in a nice, easy form. These are the acute clinical herniation syndromes, nicely presented. Rationale for ordering CT scans. We use this, and it removes any doubt in the lower members of staff as to who needs a CT scan. Pathoanatomical forms of traumatic brain injury, that requires a didactic lesson, and I have many lectures on that. Identification of patients who referral might be unsafe, that requires consensus by the professional societies. And some of these are some of the forms that you use, and all the information that you require to make a decision are on the form. And for epidural hematomas, acute subdural hematomas, chronic subdural hematomas, traumatic intracerebral hematomas, and skull fractures, all in one form. So the proposed action is to enlist professional society to deliberate on the scope of training, and would invite the county governments who have whether they give us candidates for these short trainings and a hands-on experience for 3 months at my hospital, then follow up after deployment in the county hospital. We had come up with a little budget, but it needs to be ratified by the hospital, and this is where I practice, Kenyatta University Teaching and Referral Hospital. Thank you very much.
Thank you very much, Dr. Daniel. So if Jeff or Maria are prepared, you can start sharing. Jeff, are you?
Yes.
And then Dr. Kenyatta, if you could stop sharing. Thank you so much for your presentation.
Thank you. 1 second.
Yeah.
Dr. Jeff, are you ready?
Yeah, I'm ready. Just a few minutes. My presentation to talk about evolution of the neurosurgical workforce in DRC, role of leadership of neurosurgeon to develop the neurosurgery. I can continue. Next one. Yeah. First, you must know that the DRC is the second country in Africa. It's like a continent with 2 million kilometers, 9 borders, and 18 million people, and 26 provinces, only 14 neurosurgeons, including 7 in Kinshasa, in Bukavu, and 4 in Lubumbashi. As far as we are concerned, the contribution of neurosurgeons to develop neurosurgery in DRC. Continue. Next one, please. The first neurosurgeon, can come back, please. The first neurosurgeon in Kinshasa, he was Dr. Belchika. Just back, Dr. Belchika, who working in Kinshasa at 1986 to 2080, is the only one who working for 70 million people with this country-like continent. He was traveling each month, maybe to go to one province to another province, 2 hours in the plane. And after that, the next dia, please. The next one. After that, the transition in DRC with Dr. Mujir, Dr. The next first one. You go fast, please. No. Come back, please. Yeah. You can come back, please. Again. Again, please. Yeah. After Dr. Belchika, they are coming Dr. Mujir and Professor Nsambi. You're going next year, please. Next year. I'm sorry. The next year. Dr. Mujir, Dr. Nsambi, and Dr. Safari from Senegal. That is the zone of transition of evolution of neurosurgery in DRC. And the country is too big, so that we call the neurosurgeon who is staying in diaspora of Congo the next year. That is the Professor Kalangu and Professor Kalala and Dr. Makesa coming to help us to know that how we can do to develop the neurosurgery in DRC. That is the first platform we use. The next one, please. The first platform they call it the POL, with the seven neurosurgeons, 4 for Kinshasa and 3 for diaspora. We developed the first meeting in November in 2015 to develop neurosurgery in Kinshasa. That is the 7 pioneers who begin. Next year. They call it the POL, is the platform of excellence or specialists in neurosurgery. That is the 7 neurosurgeons who are working together to develop the neurosurgery the first time. We can go the next year. Yeah. The challenge of this POL is firstly to create in 2015 the Congolese Society on Neurosurgery, in 2016 Neurosurgery POL, and in 2017, the Congo-Brazzaville, we create with Congo-Kinshasa the regional center or regional pole of neurosurgery. The deal is to increase the number of neurosurgeons to motivate young doctors, to help young neurosurgeons who finish to integrate local public system when they back in country, and to convince the government to invest in neurosurgery and neuroimaging and equipment. Next one. I say that the country was too big. You see the country in the Congo, we divide, the POL organized the country in 4 zones, the west, south, east, and north. And when you see the population, for example, in west, we have 26 million people. With before 2014, we have only 3 neurosurgery. After the organization, we go to the 7 neurosurgery today. In South, we have 70 million people. Before 2014, no neurosurgery, but today we have 4 neurosurgery. In East, the same, 14 million people. We have only 1 neurosurgeon before 2014. Today, with organization, we have 3 neurosurgery, but enough until today, with 17 million people, we didn't have neurosurgeon today. We working that to organize also on the north. And the Brazzaville also, they have before 2014, 1 neurosurgeon. Today they have 5 neurosurgeons. Until today, all of neurosurgeons in DRC and Congo Brazzaville, we have 19 neurosurgeons with the organization of POL. Next year, please. That is the POL. We can continue. Next year. And the imaging, I say that we talk with the government help us and the private to have imaging. Before 2014, in North, South, and East, we didn't have CT scan, MRI, and angiography in North. But in West, in Kinshasa, we have 6,000 CT scan, 1 MRI, and no angiography. But after organization, in North, they have today 1 CT scan, in South 6 CT scan, and East 3 CT scan, and West in Kinshasa, we have 22 CT scan. The governmental and the private working for that. They help us to have the CT scan. MRI in Kinshasa today, we have 6 MRI with this organization. Next year, please. The platform also is going to grow in all of zone. We can continue. Next year. That is the training also. We organize the training for the young neurosurgeon. Today we have 19 neurosurgeons who doing a training in many countries in Africa and in Congo. Yeah. Continue, please.
2 minutes remaining, Dr. Jeff. Thank you.
Can go. That is the neurosurgeon poll. They give also fellowship for 5 neurosurgeons for 5 years. Can continue, please? Yeah. That is the poll of West in Galiema. The governmental buy for us MRI and CT scan. That is clinic. Continue. We can continue, please. That's it. Yeah. Pass, please. That is Kinshasa also. Pass. Paul East, Paul South. Continue. That is continue. But the main activity in Kinshasa today in my hospital is neurotrauma. Continue. Neurotrauma. Continue. Yeah, please. We have an average 40,000 surgery each year, and is going up. Continue. Conclusion. You can continue to conclude. Neurotrauma is the main pathology and the degenerative. You can continue the conclusion, please. That is all of the activity you do now in transferable approach. Continue. That the conclusion I can say that the neurosurgical practice in DRC is making significant progress. First is the responsibility of neurosurgeons to become leader in their respective country and to convince the government to invest in neurosurgery. The organization of Congolese Society of Neurosurgery and Pole of Neurosurgery is the main challenge, and the acquisition of imaging equipment and appropriate technique platform. The current results are encouraging. Thank you. I'm sorry for
Yeah. Thank you, Dr. Jeff.
Thank you, Jeff.
Yeah. So we share similar pattern of neurosurgical development in Ethiopia too. Yeah.
Sega, 1 minute. I think we just have on board Professor Kalangu. He's another president of CANS, and he is actually in Addis Ababa, and he's flying back to his country. So he just wanted to say hi to the panelists.
Hi, Professor.
Thank you very much. And first of all, I congratulate with heart feeling really congratulations to the young neurosurgeons who have organized that and all the people who contributed for this successful meeting. This is great, and we people who are older, we feel really the comfort that this neurosurgery will continue. That's, I think, a great achievement. And congratulations also to Dr. Jeff Ntalaja, who has summarized very well the situation in the DRC, Congo. And as you can see, a lot of progress have been made. Maybe in DRC and maybe other countries as well, we can share how our experience in Zimbabwe. I work in Zimbabwe, but I go also to DRC. As you can imagine, I'm originally from Congo. So in Zimbabwe, what we did, because we were only 2-3 neurosurgeons, what we did is that general surgeons who were training, because they were more numerous, they came to neurosurgery to learn how to do traumatology, so that they could now cover the country, and they did the obvious traumatology. And then the following day, they will hand over the patient to a neurosurgeon. And it worked very well. Now we are about 25 neurosurgeons. So we are taking over all that work. This can be done also in the DRC, what we can do. And the other thing, which is very interesting, is that we are opening the School of Specialization in DRC, which will start next month. And these will, of course, help us in neurosurgeons and to start actually to treat all those patients. But of course, we need also to do a lot of education of people, to avoid, how to call it, dangerous behavior, which is not easy because they are coupled with poverty as well. That's also another problem. So that was my comment. Thank you very much again.
Thank you, Prof. Kalangu. It's an honor to have you here with us. Yeah. So we'll continue with the next presentation by Dr. Maria. I think Dr. Maria is ready now. Dr. Maria is from Pakistan, so she will be presenting on prevalent yet preventable causes of traumatic brain injury in LMICs, the role of law enforcement.
Hello and good evening, good afternoon, and good night to everyone who's watching us into your time part of the world. I'm really honored to present my humble work at your very prestigious event. Today, I want to just touch up a very important topic, that is the prevalent yet preventable causes of traumatic brain injury in low middle income countries, and what is the role of law enforcement. Actually, the objective of our study was basically to study the common preventable cause of head injury in Pakistan, which is obviously a low middle income countries. So why we needed to study? Because there is a death of that kind of a study, and most of the time the traumatic brain injuries affect the young population, especially the males who are in the vocationally capable and the earning age group. And there's also one thing that a few years back in our urban area, there was strict law enforcement regarding helmet use and the use of traffic laws. And so what we faced that in the urban area where the people were more well educated and well aware, there was a decrease in the incidence of traumatic brain injury, while in the rural area where there is no as such obligation of following the rules, there was a paradoxical rise, or at the most just a static incident. This was something that that led us to evaluate the role of law enforcement. So we actually need to study the epidemiology. The study was conducted on 180 patients on the institute where I work, that is the Punjab Institute of Neuroscience, which is affiliated with Lahore General Hospital. So what we actually found out was the most prevalent cause of traumatic brain injury was the motorbike accidents, because 28% patients who have presented to us have been afflicted during a motorbike. Most of the time it was a bike-car crash or a bike-bike crash. The other second cause was 23% fall from roof. The third was a Chengchi accident. A Chengchi is basically a three-wheeled rickshaw. I will show the picture later, and it is a very common, vehicle to get rolled over and leads to a lot of traumatic brain injuries. The fourth cause was car crash. That was 15%. That was one cause that was more prevalent. The incidence was higher in the urban area because there are more cars in the urban area, while the peripheral area people do not have that much number of cars. It was visited by the pedestrian injury that constituted about 8% of what we have received in traumatic brain injury. And 4% were from falls from stairs. And it was very unfortunate that most of the time it was in the pediatric age group. This is, the graphical presentation of what I have told before. The incidence of head injury is much higher in rural areas compared to the urban area. In the rural area, it exceeds about 67%, while in the urban area, it's about 3%. So literature from Pakistan, I want to just quote here, in a study by Bhatia et al. In Karachi, which is a very remote country where law enforcement is much stricter than any other part of the country. The odds for dying for those people who wore a helmet were much less. That is, the adjusted rate for 0.37, and the odds of sustaining a severe head injury were also much reduced in those who used a helmet. So what was the thing that we wanted to say was it was basically dependent upon the compliance with the rules. Claire et al. Compared the compliance with law enforcement of helmet and seatbelt use and found out that the average seatbelt use rates were 20%. That was much higher on the motorways, because on the motorway there's a lot of law enforcement, there's a lot of checking, there's a whole police, a motorway dedicated police that whoever is wearing or not wearing helmet and seatbelt. While they were lowest on the rural road. That was just about 5% because there is not much, monitoring on the rural area. So unawareness and law, useful as seatbelt not fitted, discomfort, forgetfulness, low speed, and careless attitude were the major reasons why people were not using those rules at all, especially in the rural area. The seatbelt rates were directly proportional to the law enforcement strength. So wherever there was a lot of law enforcement, where there were strict laws and people were, getting fined and when released a ticket, people were more careful regarding following, like a ritual following of those rules as compared to those areas where there is, a very low law enforcement. So what was the predisposing factor in the rural area? There was a low, first of all, a poor level of education and awareness and the standard of living. And the common cause of TBI, as I have told before, like the motor vehicle accidents, fall from roofs, three-wheel vehicle like the Chingchi rickshaw, as you can see on the top left. This is the Chingchi rickshaw. Fall from stairs and the pedestrian age. These are all much prevalent in the rural area as compared with the urbanized area. So these were the exposing causes were more prevalent in those areas. Fall from roofs is common in rural parts where the roofs are not being protected by any proper railing. Three and two-wheel vehicles are much common in the rural area. The untrained, unaware drivers overload these vehicles with more passengers than the vehicle can bear, and actually they get, they lose their balance and they roll over. Roads are poorly developed, badly maintained. There is usually no way to control the traffic at all. Stray animals like cows and sheep, as you can see in the picture, they stroll easily on the roads that may hit the vehicle and even the pedestrians. The fall from stair group has a higher incidence in rural areas where again people do not protect the stairs with railing. Moreover, they even use a rope railing and even a bamboo ladder in their home in their houses. Motion engine from
Sorry.
Okay, so RCs in the urban areas, basically teenager, they are thrill lovers and etc. Car crashes and pedestrian injuries. You can see this is the one building. This is very common in our urban areas where the teenagers are much more interested in this kind of thrill. Most of the factors, as you can see, they are preventable. They would be prevented. They were easily prevented with the law enforcement. As law enforcement, we can see used in the urban part of the country with the traffic laws are followed and there is strict law enforcement, the incidence advantage is much less. So this is another study which was conducted about 6 months after the enforcement of the helmet law, and they noticed in Lahore, which is a major city where the law enforcement is much stricter, that there were 80% reduction of head injuries due to bike incidents. 80%, just the use of helmet protection. So this was a very significant finding regarding law enforcement. We have to basically obey the laws. We should have what I think that we should propose and suggest law regarding house architecture, and every house should have their plan first approved by the authority, which is according to the proper rooftop designing, which is protected with the railing, safe architecture of stairs, and windows should be protected with grills. You can see this is the rural area where the rooftops have not been protected at all. Traffic laws, should there be strict traffic laws, and everyone should be given a license, and the license should be suspended if the person is not following the rules. And these are the signs that everyone should basically know about. Many people do not even know about this sign. Every car should be registered, should be for fitness. Every driver should be, given a license after passing a driving test. And the reason of every RT should be investigated authority. Speedometer should be there so that we can just check anyone who is overspeeding. Every traffic hours should be, they should be dedicated hours for the heavy traffic, which includes the dumpers and loaders and trucks. And they should not be allowed to, drive during those rush hours when other people are going. And when the heavy traffic is on, the road should be blocked for the normal traffic.
Thanks, Maria. Your time is up. If you can start rounding up to your last slide, please.
Which one?
I was saying your time is up. If you could start going to your last slide, please.
Okay. If this is just about the roads, the proper roading, and why there are a lot of accidents because of poor roading, underpasses should be there. This is just a new discovery about bikers. How can bikers protect? So this is basically TBI is the latest burning issue, and safety should be used first. Thank you so much.
Thank you very much, Dr. Maria. So we'll proceed with the next presentation. The next presentation is by Dr. Frem Pongma from Ghana. So it's a case presentation about 3 traumatic brain injury patients at Korle-Bu Teaching Hospital. So Dr. Frem, you can start sharing
Friend is a medical student.
Okay.
Hello, my name is Frimpoma Wadi. I'm a fifth-year medical student at the University of Ghana. My team and I conducted a case report on 3 traumatic brain injury inpatients at the neurosurgical unit of Korle-Bu Teaching Hospital. This is a tertiary hospital in Accra, the capital of Ghana. So traumatic brain injuries are one of the many categories of physical traumas that could be documented more thoroughly in Ghana. Korle-Bu Teaching Hospital gets about 25 head injuries a month, of which 10 usually need surgery. So the purpose of the project was to assess outcomes of TBIs and to see if recent research on the condition has influenced management of patients in the hospital. We went to the neurosurgery unit during the month of March 2019 and got data from TBI patients who were going to have surgery. We assessed their clinical progression via the Glasgow Coma Scale. The extended Glasgow outcome score was recorded if the patient was discharged. We also recorded other signs that the patient had after surgery. So for our results, we recorded 3 patients, RT, DQ, and II. The patients were all males, and they were 33, 24, and 23 years old. As mechanism of injury, patient RT was assaulted, DQ was knocked down by a vehicle, II crashed into a wall on a motorcycle. For the post-resuscitation GCS, RTs was 10, IIs was 11. And due to data reporting difficulties, for DQ, we couldn't get a post-resuscitation GTS, but the earliest recorded GCS was 14. For diagnoses, RT and II had skull fractures, and DQ had an epidural hematoma. On this slide are CT scans. They're not scans of the patients included in this study, but of patients on the ward who had similar injuries to the 3 patients. It was just to show that these type of injuries are continuously coming to the ward, so a wealth of information is actually available to us to analyze and evaluate healthcare. All our patients had surgery within 24 hours of admission to the hospital. Also, our neurological assessment revealed progressive improvement in neurological function as a trend for the 3 patients. On discharge, RT had a GOC score of 3, DQ had a GOC score of 8, and due to data reporting difficulties, we couldn't get a GOC score for II, but he had a GCS of 15 at his final assessment. So in all, we concluded that the urgent care treatment at Korle-Bu is timely because all patients were operated on within 24 hours. The care is also of good quality since patients had a trend of improvement in neurological function after surgery and while they were on admission. Our research is also showing that the record keeping can be improved at the hospital because we're not able to get all the patients who are admitted during our selected time period because of such issues. In spite of this limitation, we saw a trend of younger patients being victims of road traffic collisions, which is in line with previous research done in the country. This means that the country's human capital is being affected, and therefore our economy. Also, many people involved in such accidents are not able to afford such care. Our recommendations are therefore to improve our record keeping in order to generate more robust research in the area to reform policies. This would help preserve our human capital, cut healthcare costs, as urgent surgical care is expensive in our parts. This recommendation will also mitigate the effects of this silent crisis. So thank you for listening. And I would like to thank Dr. Kumi, Dr. Dakura, Desmond, Ruben, and Angela for doing this project with me. My team and I will try and answer any questions as best as we can, and any questions we can't immediately answer, we'll find a way to answer it later if you give us your contact information. Thank you.
Wow, Frem, congratulations. That was a great talk. And as a medical student, well done for speaking to such an intimidating crowd. And what I figure is Ghana is a very safe country if you guys have such few TBI. So I'll definitely be visiting sometime soon. Tsegazeab, over to you. We are going to our last speaker. Tsegazeab, can you hear me? Okay.
Yeah, I was just got disconnected. Sorry.
No problem. We're
Yeah.
now at our last speaker, Stefan from Cameroon. If we can start sharing a screen, and while he's sharing a screen, we just want to say thank you to the whole audience. This really was a marathon, and a large portion of you have still stayed online, which is excellent. So let's hand over to Guy just to introduce our last speaker.
Stefan Ngombo is from Cameroon, so he will be presenting on outcomes of traumatic brain injury in Cameroon. It's a cross-sectional study. So I will kindly invite Dr. Stefan to share his PowerPoint.
Hello, everyone. I hope you can hear me.
Yeah, we can hear you.
I will try to share my screen. Can you see my screen?
Yes,
yes, we can see your screen.
Thank you. I wish first to thank the Young Neurosurgeon Forum for this opportunity to share our work. We started the outcome of traumatic brain injury in Cameroon, a cross-sectional study. The author of this work began not have any conflict of interest. I think as introduction, traumatic brain injury is the leading cause of death and disability related to trauma. The burden of traumatic brain injury is proportionally affected low and middle income countries. The incident rate in Cameroon is at 572 cases per year. This is almost twice the global incidence. This study aims to identify factors associated with adverse outcomes in the management of Cameroonian patients with traumatic brain injury.
Dr. Stefan, your sound is not clear. Maybe.
It's a background song.
Yeah, it's
better now.
You can be close to the speaker if it is possible.
Okay. Is it better?
There is still a background voice, but yeah.
Okay. Sorry about that. This cross-sectional study includes all traumatic brain patients treated between January 1st and December 31st, 2018 at two Cameroonian referral hospitals. Socio-demographic and clinical data were extracted from patient charts and admission registry, and the analyses were done with the SPSS version 26. Independent test, odds ratio, and cumulative mortality hazard rates were computed. A p-value less than 0.05 was considered statistically significant. Our results: during our period of study, 171 patients aged with the mean age is 38.63 years old received treatment for traumatic brain injury. Most patients were male, and almost 89% of patients were uninsured. Almost 50 patients were referred from other facilities to our study site. 44.4% of patients were admitted within 4 hours after their injuries. 27.5% were treated surgically. After by 28 days post changes, almost 66 patients had a recovery completely. Patients admitted 4 hours or less after their injury had better outcomes, with 58 complete recovery and only 8 disabilities. The mortality hazard rate of the patient treated surgically was less than those treated conservatively. during the first 9 days following admission. Surgical treatment was associated.
Dr. Stefan, can you go to the conclusion and maybe we can see the important points in the conclusion?
In conclusion, we identified factors associated with unfavorable outcomes among Cameroonian TBI patients. This result can help improve triage and referral practice in Cameroon. Also, this will aid policymakers in developing content-specific pre-hospital guidelines. Thank you for your attention.
Thank you very much. Thank you very much, Dr. Stefan. This is our last presentation, so we thank all the presenters. Maybe I have one question to Kee Park, and also one question to add. So my question to Kee is that now we are developing the neurosurgical training in local, but what our challenge is that the resource, the logistics is not adequate. So there are many traumatic brain injury patients, but the ICU care is not that much adequate. And then the pre-hospital care is also not adequate. And the neurosurgical equipment are not that much adequate. So most of our neurosurgeons go to the rural areas, but like they don't have the adequate setup to do the surgeries and so on. So maybe those are the things, maybe if there are any proposed solutions on that.
Yeah, it's a great question. You know, and we're not going to fix these problems through just training neurosurgeons alone. I think that's one part of the solution. But we need to all work together on this. And this is the reason that President Franco Servadei created the Global Neurosurgery Committee. Because there are a lot of activities, all worthwhile, with great people, but they're all working independently. I remember working in Addis Ababa at the Korean hospital, and then we would have teams coming into the Black Lion Hospital, and we could have clearly shared and resources and coordinated our visits to have better impact, but they were all working in silos. So the goal is to make sure that anyone with a head injury should be able to access safe and affordable neurosurgical care wherever they live. Right? If we all agree that's the goal, the only way to approach that successfully is a system level change, and we need governments to commit to investing in building facilities that are and training neurosurgeons and providing equipment. So the best way to do that is go together with other specialists, other doctors, other surgeons, other anesthesiologists. And so neurosurgeons should be part of, and we are, the overall global surgery movement, right? We talked about the national surgical planning processes that are all happening now. And I can assure you, one of the Global Neurosurgery Committee's objective is to make sure that we have neurosurgeons at the table. But at the same time, we need to be conducting good research, looking at data from these areas. What are the epidemiology, unique features of that? What are the needs? What are the best ways to scale up neurosurgical services? And so produce those kinds of solid evidence, and then coordinate all of our work together so we can achieve system level neurosurgical surgical system strengthening together.
Thank you, Kee Park. So my other question is to Adio. So we have a lot of patients with frontal contusions and increased intracranial pressure. So do you have any any decompressive craniectomies that are done for good GCS, but whom you anticipate that a patient will deteriorate afterwards? Because in the absence of ICP, it might be difficult to monitor this kind of patients.
I think.
Hello?
Okay, so I'm not sure, is he there to answer? Because this will be the last question. particularly because I think we're running out of time.
Okay. So maybe we can like discuss further later. So
I think afterwards, whoever's keen on the floor, we'll still remain and we'll round up whatever questions. But I think a 4-hour marathon, well done to everyone. Before I hand over to Ignatius, I just want to mention that for this webinar, a large portion of people that have attended are our colleagues in anesthesia and obviously as surgeons. We need them before we put our patients to sleep, but this just highlights the importance of communication and all of us working together. So the World Federation of Societies of Anesthesiologists are really keen to reach out to surgeons within Africa that have poorly resourced care in terms of anesthesia, just to build bridges and networks. So hopefully you've captured these emails on the screen. Thank you very much.
Thank you so much. Thank you, Sega. Thank you, Beverly, for the good job. Thank you, Kee, Franco, Tony, and Angelos for.
Ignatius, you look tired.
Note, our call.
What's happening?
Yeah, no. Yeah, it's been 4 good hours. The Continental Association of African Neurosurgical Societies, Sokorashi, to give the final word before we call it the end of the day.
Thank you very much, Ignatius. It's, as Ngobila said, been a marathon, and it's been a wonderful marathon. Wonderful from 2 perspectives. One is the amount of knowledge that's been shared across the globe, actually, with people from Pakistan, from Indonesia, USA, all contributing. It's heartwarming. That's number 1. Number 2, it's given us the opportunity to recognize some of the solutions that are being pointed out. Tony mentioned research, and we actually, just on this panel, see the future of collaborative research unfolding with so many interested young neurosurgeons from different parts of the continent collaborating with international colleagues. So we've already got a template of future collaborative research being set, and that's again very heartwarming to see. So I think, judging by the presentations and judging by the enthusiasm on a Saturday night or Saturday evening for so many people to sit there listening to talks and how to improve neurosurgery, and then be inspired by the Kee Park and Franco Servadei on how to do things better, and then Angelos showing us the way. I think it's really been a heartwarming session, despite the timing and the 4-hour marathon. Everyone stuck to it. So as CANS, I can only see a very positive aspect to the future of neurosurgery, because I can see a lot of young, enthusiastic neurosurgeons collaborating with each other and being guided by the leadership of the World Federation and the committees there. So congratulations to the organizers. Well done to the participants. And obviously there's a variation in the level of presentations, but that's understandable. You have medical students working with international researchers on the same platform, so you're going to see these this diversity of a level of presentations. But again, that gives us an opportunity to learn from each other. So congratulations, and thank you very much for organizing such a wonderful marathon of a webinar. Well done. Over to you.
Thank you, Prof. Thank you everyone for joining in. It was really a great evening, and we all will keep in touch. And please just also drop your We've got your email addresses, so we'll follow up with emails and try and look through the Q&A and see what we haven't answered and report back by email. Thank you so much to everyone. Prof. Kee Park, thank you for staying till the end. Prof. Figaji, likewise, thank you for staying till the end. And thank you to all the wonderful speakers. We're incredibly proud of you. And there's a bright future on our continent. Have a good evening. Bye, everyone.
Have a good evening. Thank you very much.